Hello, everyone. My name is Dr. Richard Horowitz, and I am the co-host of the Doctor Talk Healing Lyme Summit 2.0. And it is my great pleasure to introduce to you a good friend of mine for a very, very long time, Dr. Stephen Harris. Steve, thank you so much for joining us today. We're going to be discussing lab testing in chronic Lyme and tick-borne disorders and some integrative strategies. So again, Steve, thank you for taking time out of your busy schedule.
Thank you for inviting me.
Yeah, sure. So, Steve, why don't you tell? I think a lot of people actually know who you are, but why don't you just tell people a little bit about yourself and kind of how you got into this?
Right. So I'm a family medicine doctor, and I've been in practice now for nearly 25 years, working in Lyme and chronic infection and now chronic complex illness space. My father, Nick Harris, started a lab called IGenX, and I was an employee with them for a while. I've done research with them, got to hear really from the beginning when people like you and Joe Burrascano were seeing some of these patients early on, kind of hearing from my dad's point of view when I was still even pre-medical school, what patients and doctors were experiencing for how to approach this new cohort of patients. So I've been involved in the Lyme world and the lab world peripherally for quite some time now.
Right. And you've been working kind of peripherally with IGNX now, even though your dad passed. And by the way, for those of you who did not have the great pleasure of knowing Nick Harris, I just have to tell you, Nick was one of the most generous, kind, warm-hearted people I ever met, and of course smart. Nick was one of the founding members of iLads with myself and Joe Borascano and Steve Phillips, Andrea Gato, Terry McKnight. We were all there from the beginning. Nick rented out a space in New York City. It was a hotel room. It was like on the 16th floor somewhere, this little room. And we're signing documents, starting iLads. And every year, and you know this, Steve, from his generosity, he would support iLads. He would take everyone out to dinner. He would make sure that iLads had whatever the finances they need to keep going forward. I mean, really, if it wasn't for your dad, I'm not sure iLads would be in the situation it's in here. So I just wanted to give him a shout out wherever Nick is right now. Hopefully, he's driving his Maserati someplace in the Pure Lands. But hopefully, I just wanted to give him a shout out because he was just such a wonderful person. And of course, I had the great pleasure of knowing you and your mom and your whole family for many years. So yeah,
Right.
yeah. So yeah, you're working peripherally now with IGeneX, helping a little bit with lab testing, correct?
Right. So I work with IGenX as one of their clinical consultants. I use lots of labs besides IGenX. I do quite a bit of Lyme testing and co-infection testing, and so I approach the patients in several different ways with various labs, knowing full well that Lyme disease at least is a clinical diagnosis. The labs are meant to support a clinical diagnosis, but by themselves are not meant diagnostically.
Right. And of course, the great news for IGeneX is you recently got FDA approval, right, for the immunoblot for the home testing with the Lyme immunoblot. So that's really great. And of course, I started using IGeneX. My God, I don't know, was it 20, 25 years ago? I mean, I discovered Babesia in New York State, really thanks to Johnson and Nick, right? With the Babesia fish test before anyone was saying it was really there. Now, of course, we have the Babesia immunoblot, the Lyme immunoblot, the relapsing fever immunoblot, the Bartonella immunoblot. So talk a little bit about that, Steve, about when you have a patient either you're seeing for the first time or who's got ongoing symptoms. How do you look at those lab tests? What's the panel of tests you like? And then we'll talk a little bit about interpretations of those lab tests.
Right. Well, it's the approach is not as straightforward as it might seem. Partially because a lot of patients, by the time they get to me, by the time they get to you and some of these other docs who have been in this space for a long time, a lot of them are coming in self-selected, right? They've been diagnosed or they've gone through several iterations, and so a lot of times Lyme, they come to Lyme often by default after having looked at many things. So there's two different groups of people at least. One group who come in with a huge constellation of symptoms. I'm going to look at Lyme and co-infections as part of an overall workup, mostly because, I do have to play devil's advocate because I want to make sure I don't miss anything key. I don't want to miss cancers. I don't want to miss autoimmunity. I don't want to miss other infections. And so I'm not just when patients come in and they haven't had a whole battery of testing. I am going to try and find as many things. There's so many differential diagnoses that we have to consider, such as lupus, but such as parathyroid issues, such as other hormonal issues. So with these patients, I really want to take a very broad view and perspective of what I'm looking at. So we'll get to those maybe later. But if we have someone and I'm really trying to focus on Lyme and other tick-borne infections, I think about it in a few ways. Partially it's financial, because there is a somewhat of a debate in the Lyme world about, do the co-infections have a real clinical significance in the absence of a Borrelia infection, right? And so there's many doctors who feel that they do. I find more that Lyme I look at as one of the drivers of these co-infections, that many of them are actually co-infections, and that were someone infected with a Babesia, especially like a Babesia microti, maybe not Oticali and Duncani, but some of the Babesia infections may not have as much clinical significance in the absence of something driving it, whether it's because it's lowering complement or it's having other immune effects that's making Babesia a thing by itself. Same issue with some of the rickettsial infections and with even Bartonella. Now, we do see, of course, cases where people may have Bartonella, whether it's from a cat scratch or even a tick bite, and they are quite symptomatic, and we don't actually find Lyme. Sometimes we still suspect that there's Lyme, but I do find that by and large, I really want to see if Borrelia infections, Lyme, primarily is at play here. And so I do discuss this with patients, but a lot of times I'm going to try to find Lyme first, and then if I find a positive Borrelia infection, or if clinically if it fits, then I'll go back and do co-infection. So sometimes I'll split it up. Now, some people want to come in, and it is a question, really, I think, of time versus money, if you're going to be doing all testing at once, or if you're going to start with Borrelia first, because sure, you can save money on not doing a lot of these extended panels, but in a practical world, if I have someone and they have Lyme and they have Babesia and they have Bartonella, I'm typically going to treat Babesia or Bartonella before I really engage in a lot of Lyme treatment. That being said, I will often present it with the patient of my logic of why I just testing for Lyme first. And then in other cases, when it makes sense to look at all of the infections together, then I'll do that. So the way to think about Lyme testing, for Borrelia testing at least, there's indirect testing and there's direct testing. Direct testing is the clearest way to see if the spirochete is present, or pieces of the spirochete is present. Culture being the most effective and best way to find the organism. Culture is obviously a very difficult process. It's been rife with problems, and so culture is still not perfect. There's definitely been some headway into culture, but so one of the best things that we have is PCR, looking at DNA. Another way that is being developed is RNA, or FISH, which would the FISH testing with a fluoroscopic in situ hybridization, long term, for saying that you can see the RNA under a microscope, that's the RNA tagged to a marker, and that you can actually visualize the pieces of the RNA in the organism, and then at least you know that the organism is somewhat active, or at least fully present, because there's the idea that if you only find DNA, that there is often a criticism that people could have positive PCR even in the absence of an active infection. Now, I don't truly believe it. I think the body does a pretty good job in eliminating DNA pretty quickly if there's no organism that's active and attached to it. But it is one of the criticisms of PCR testing, that there may not be live organisms. So, but I still think that when you find a PCR positive, or a FISH positive, or culture positive, that you really know there's an organism there. The other
Right. And the other direct testing, Steve, the urine antigen testing, right? IGeneX used to do the Lyme urine antigen testing, but there's other antigen testing using the 31, right, that other people will use also. So, I mean, do you use that test at all with the urine antigen testing?
Of course, and thank you for reminding me because I do think in the past it was probably one of the most important tests that I did. I don't use that as a upfront test, and I'll explain why in a moment. But the urine antigen testing, the idea behind it is that these spirochetes that they have several proteins on their surface, and called antigens in this case, and antigens are usually what our immune system responds to. And so they have there's different antigens on the surface. The antigens themselves we can often detect in the urine. And then there's been testing way back when. I think Steve Schutzer was doing some work for years. IGeneX has done some amazing work. There's some newer testing now that's looking at Lyme urine antigen with some new labs, and so it still is quite exciting, especially when we know that Borrelia really has a propensity to infect the bladder. It's sometimes one of the only ways to get it, and it is uh, one of the few ways that I can be confident after I do a provocational test, especially, and if I do enough of those urine tests, I use that quite I think quite effectively to help rule in and sometimes even partially rule out the infection. So yes, thank you. The urine antigen testing does have quite a bit of value still. I don't use it as much, especially not in the beginning, usually because there's so few Borrelia organisms from a microbiological standpoint. It's unlike, its dumber cousin Treponema that causes syphilis, where almost every cell is infected. Borrelia doesn't infect that many cells, and so by just checking your urines that are unprovoked, you could be doing a lot of testing before you hit a positive, maybe even,
Right.
two for every 20 tests or so that you'll find. And so if you provoke with an antimicrobial and you strategically time it when you should kill bugs and then check the urine, it can be pretty useful. But it's not always a great test for initial patients because giving someone antimicrobials before you really know their body and their history, I don't often start with heavy antibiotics for them. The so I do think it is an important point. The other form of testing that is the most common, of course, is indirect testing. That's looking at your body's response to the presence of the bugs. So you're interpreting or interpolating that there's organisms based on one's immune response to the said organisms or to the antigens on the organisms by looking either at antibodies or and more recently looking at T cells, looking at a different kind of immune cell and seeing if those T cells respond when they're sensitized with the organism. And so there's a lot of ways to evaluate that. I think that's really the starting point for most people. I think it's the simplest way to start for most people. The CDC still recommends using antibody testing. They have preferred the so-called two-tier testing, where you're looking at the overall quantity of antibodies that one makes to the organism, and then if someone makes enough antibodies, then they'll look at the specific or suggest that you look at the specific antibodies. We've all found over the years, and there's a lot of studies that prove it, is that Borrelia does not induce a huge antibody response. So when you're trying to do quantitative measuring in the form of an IFA or an ELISA or a C6 peptide even, other than in the acute phase, that a lot of people don't make enough quantity to even get to that next tier, the Western blot and now the immunoblot, um, which are very similar, but one actually is the organism, pieces of the organism, and the other one is using a recombinant form of the antigen to see if there's an antibody antigen mixture or binding effect. So the the initial screening test, it is one of these crazy situations where the screening test is less sensitive than the confirmatory test. And so the whole point of a screening test is to have too many positives, and then what you do is with all those too many positives, then you find which one of those positives are true positives. This is backwards because the test, it really seems to stop before people get to that second confirmatory test, and so many people are being missed. And this is just this is Lyme and ILADS 101, is that there's so many people who are not getting the proper testing because of the way that this was dealt with back since 1996. At a conference in Michigan, where they decided that two-tier testing was what they were going to use. Now, as you know, the intent of that was for state funding to see what the to do surveillance testing to see how many new cases would be found in each state. All they cared about were incident cases or new cases. And in new cases, you may not miss as many, and they didn't care about the prevalence of Lyme. They cared about how many new cases, and based on how many new cases, how much funding should every state get to address Lyme disease, and how much of an infrastructure should be created. So the whole point of that two-tiered testing was not meant to help with diagnosis. It was help to create a baseline rough idea of surveillance cases. And
Right. So you're bringing up some important points, Steve. So you said it early, and I'm going to just kind of sum this up for people who are listening. You're listening to Dr. Stephen Harris, who has been in the Lyme world for the last 25 years, grew up with one of probably the best immunologists in the world for Lyme, his dad, Nick Harris. And what we're discussing today is that Lyme is a clinical diagnosis. Using the testing basically to confirm that diagnosis. There's indirect testing like IFAs, immunofluorescent antibodies, ELISA, C6 ELISA. The C6 ELISA, by the way, and I'll just fill in some gaps here. It checks for at least 3 strains: Borrelia burgdorferi sensu stricto, but also Borrelia abzelii, Borrelia guarini, which are European strains, which we are finding now. But the C6 also overlaps hard tick relapsing fever, Borrelia miyamotoi disease. So you will see some cross reactivity. And the ELISAs, you're not always going to pick it up. Steve was describing earlier that when you do the two-tiered testing that health departments use to epidemiologically screen large populations, you're going to miss. It's a coin flip. You're missing about a little over 50%. 50% of those patients will be missed. And that's why we have to use other testing. And we were describing direct testing, whether it's by PCR, DNA, fish testing, culture testing, urine antigen testing. We didn't go into phage testing. We can discuss that in a bit from Red Labs about some doctors will use it. But actually what I do at this point, and going back to clinical diagnosis, is we developed our questionnaire and published it with New Pulse researchers in 2017 in 1,600 people from 3 medical practices. So we give people the HMQ, the Horowitz-Emsitz questionnaire, which was based on Joe Boroscano's work. We score it, and we look to see if they have good and bad days with symptoms coming and going with migratory pain, because migratory pain is the hallmark of Lyme. Migratory muscle pain, joint pain, and nerve pain being actually the only disease that we know of that really causes it. And then if questions 1 and 22 are positive, fevers, sweats, day sweats, night sweats, chills, flushing, air hunger, we suspect Babesia. Now, what Steve didn't get to yet is in clinical practice, once I look at that and I see, oh, you score high in the questionnaire, over 63 is 2 standard deviations above the mean. You've got a multisystemic illness. You rule out other diseases. Very important point that Steve was making earlier. You have to do a differential diagnosis to rule out other diseases. But I will go, if people can afford to do the immunoblot from IGeneX, I will start off with an IgM IgG because it's recombinant DNA. And all I need, I play the game Lyme Bingo, which is if any one of those bands on the immunoblot, 23 OSP-C, 31 OSP-A, 34 OSP-B, 39 83/93 is positive, I know you've been exposed to a Borrelia species. And the problem with a Western blot, if you do it through the local labs, it's only checking 1 strain. And the 31 can overlap other diseases like Epstein-Barr and other viruses and autoimmunity. So in a simplified world, once those other diseases have been ruled out, and you've got migratory pain scoring high in the HMQ, which you can find on our website, cangetbetter.com, and you can download it and take it. Our first test is actually the IGeneX immunoblot, IgM IgG. And you're right, Steve. I mean, it can get expensive. And I certainly do tick-borne testing through Quest, LabCorp, BioReference, whatever people might need to do for Ehrlichia, Anaplasma, Rickettsia, Rocky Mountain, Q fever, typhus, tularemia, we will do those Q fever. We'll do those tests so that people, the insurance covers it. But fortunately, the IGeneX testing, if you just do one or two, it's not that bad really. And I know they discount the tests. But I do find the Babesia fish test my best test for finding Babesia. And I find the Bartonella fish test to be the best test for finding Bartonella. I'll get Babesia immunoblasts positive and Bartonella immunoblasts positive, but for proving active, as you said, with RNA. And by the way, I agree with you. The PCR, everything I've ever read, and I've spoken to lots of doctors about this, the DNA should be cleared from the system in several days. If you're PCR positive for hepatitis B or C, nobody's going to tell you you have a false positive PCR for hepatitis, right? So you got to use the same criteria for Lyme as you do for other diseases. But I have to say that panel approach, it's made a huge difference for me that, when I've ruled out other causes of sweats and the fish is positive, I know I've got to treat it with things like tefenaquine and atovaquone and the rest. So I just love the panel approach from IGeneX. And I do use T Labs. I find T Labs, their Lyme PCR, their Babesia fish, their Babesia oticoli. I am picking up Babesia oticoli through them, and I'm picking up their Bartfish positive. In fact, confirmatory on IGeneX when people are asking me, well, can we be sure? And it's like, I've seen them positive in both. So are you kind of sometimes having to do that with Steve, with also like using these other tests confirmatory? You're pretty confident with the ones you're using.
A lot. No, I use T-Lab a lot. I use IGeneX. I use their fish a lot for the co-infections. The fish testing is my favorite testing, both T-Lab and IGeneX. And so I find that they're the most useful when I need to make decisions about treatment now, and especially if the clinical picture is hazy, like if someone has both Babesia and Bartonella symptoms that are overlapping, with Lyme, then those tests are very important for me, especially when we're deciding on treatments. As far as like, are we going to put someone on Dapsone? Are we going to put someone on IV ceftriaxone? Are we going to do this? I really like to know what the fish is showing me. So I think that that's very useful. I also do like, to be fair though, I really like Infecto Labs T cell testing. I like IGeneX's T cell testing. I like Armen Labs testing, and I like because those T cells, which are they're not necessarily memory cells, but these T lymphocytes, when they've recently had exposure to these organisms, they're going to release their interleukin-2. They're going to release their interferon in ways that tell me kind of where we are in the disease process too. So I do also use those as far as sometimes tracking disease. I'm
Yeah.
not often using them as diagnostics, but once I have a diagnostic established, I think those are really giving me some real-time data where we are in the disease process. Um,
Yes.
but to your point, I think that, and I talk to doctors a lot about testing for like, what's the one thing I'm going to do for Borrelia, for Lyme, and I'm going to do the immunoblot. I'm going to do the immunoblot IgM and IgG, and which is another important point about this, is I think that we all in the, not all, but I mean many of us who have been dealing with tick-borne infections for so long, we really understand and appreciate the importance of a persistent IgM. And I think it's one of the key hallmarks of this debate about, is there a chronic infection versus is it post-infectious? It's not that it's the same IgM molecule that we're looking at years ago as we are now, but because of these different proteins that are shown on the surface of the organism at different times of the disease, when the tick is feeding on the Borrelia, there's going to be that antigen that relate OSP, and there's going to be occasionally 39, the BMPA, and then there's going to be, of course, the flagella protein 41. And then after 6 months or so, when it gets into our body, our immune system is then going to start recognizing other proteins on the surface of these organisms. These organisms are going to switch. The 23 is going to be internalized, and we're going to those spirochetes will put out that 30, equates to the 31, the OSP-A, and the OSP-B, the 34, the 8393 complex. So So when we see an IgM that's positive and it's more than 6 months after the infection, even years after the infection, and we get patients saying, "Well, the doctor said this was a false positive because it was an IgM," especially to your point, after ruling out these other infections like Epstein-Barr, that it's this IgM is really important because after 3 or 4 months, that molecule is going to degrade in the liver. And so if you're still making an IgM, it's because it's being made again. It's looking to the body like a new infection. Uh,
Well, and Steve, you bring up a great point because that is a big controversy, by the way, among doctors out there about the meaning of IgM. And the studies that we've published, we found that 45% of our chronic Lyme disease patients had positive CDC IgM Western blots or immunoblots. It turns out Johns Hopkins University, John Alcott, found exactly the same figure, 45%. And the reason for it is that when Borrelia invades the lymph nodes, it gets rid of the part of the lymph nodes that with the B cells that makes IgG antibodies, right? So you're left with IgM. And some of these patients, in fact, have chronic variable immune deficiency. When they get Lyme and or Bartonella, their immune system gets suppressed. So some of these people, they don't make enough immunoglobulins. They have subclass deficiency. You can't rely actually even on some of these antibody tests because they're immune deficient. And speaking of lab testing, people out there who are listening, you've got to be doing immunoglobulins and subclasses in all of these patients. And because of what long COVID now is doing to the body with T cell exhaustion, you also should be checking your natural killer cells, your CD8, CD4, CD8 ratios. These are like really important. We're also now starting to use radiance diagnostics to look at their COVID long hauler panel and finding out what kind of chemokines and cytokines are going on to be able to differentiate what is Lyme, what might be long COVID. We see a lot of elevated VEGF in these patients, vascular endothelial growth factor, which I have this conversation with Bruce Patterson all the time. You know, is it COVID stimulating the endothelium and inflammation, or is it BART, or is it both? Right, and we just don't know at this point, right, what it is. But no, great point on the IgM because that's a big point of contention with many doctors.
Well, then the other thing is that I will follow IgGs, of course, but a lot of these folks don't make, at least on the West Coast and in Central. Maybe if they're getting bit by ticks, every few weeks. On the East Coast, of course, then maybe they'll have more brisk IgG positivity. But a lot of us are seeing that it's only when patients start getting better that they actually seroconvert to IgG. So it's and so when I see patients who are IgG positive when they're presenting to me in the beginning and they're actively infected, I almost look at that as a favorable sign that that your immune system is already aware of this infection, and so at least it's helping to address what we're dealing with, because most of the time these folks who are the sickest, their IgGs are negative, or are almost completely negative.
Absolutely. The sickest patients do not make antibodies. So you're right. When you see somebody who lights up on an IgG, which by the way, in my world is rare, most of the time it is the IgMs, not the IgG. But you're right. I mean, you can follow the bands. If you see new Borrelia specific bands over time, that's how you know the body's still recognizing that, right, the bug is there. So it's, again, you're not using two-tiered criteria of an ELISA followed by a Western blot, which is, again, for epidemiological purposes for health departments. We're looking at those bands. And by the way, you brought up Dearborn, and I think the people listening out there, many know this, but they took out the 31 and the 34 band when they put out the Lymerix vaccine because it was going to cause a false positive. Now, the VLA15 is about to come, right? We're going into phase 3 clinical trials now for the new, Lyme vaccine. So again, they're not putting it back on, but you can ask the local labs. You have to ask for it. Ask them to run the entire and give you all the bands. If they're running a Western blot, tell them you want to see all the bands, not to leave out 31, 34. A lot of times they will not provide it. IGNX always provides it.
Right.
Yeah.
Yeah, no, that it's such an important point. That 31 and the 34 are so important in later Lyme. That if you have a Western blot or an immunoblot that doesn't include those bands, you're going to miss many cases
Right.
of persistent chronic Lyme. Yeah.
So lab testing, in general, because this is good, Steve, because we're filling in a gap for doctors talk to talk about this. When I see patients, you were discussing earlier, how many tubes to draw on people, you could do it intermittently. the joke is it's like going to the Red Cross when they come to my practice because I'm draining them probably a half a liter dry by the time I'm done because I'm sending out four. I prefer getting it all at once, right? Because I'm doing a CBC and a biochem. A lot of times I'm running natural killer cells and CD4, CD8. I'm running the full tick-borne panel locally, right? Locally, when I can do it. I'm running mast cell markers with histamine, chromogranin A, tryptase, prostaglandin D2, immunoglobulins and subclasses. I'm running hormones. I'm running sex hormones, testosterone, estrogen, thyroid hormones, posterior pituitary hormones, mineral levels, red blood cell mineral levels, right? So it's kind of very comprehensive when I'm seeing patients for the first time. I'm always thinking the 16-point MSIDS model that there's six factors that drive inflammation. I discuss it sometimes like six rivers of inflammation going into an ocean of inflammation. And I'm also doing, mold testing on the first round now because I'm finding so many people are loaded with mycotoxins. And I'm doing a DHEA cortisol adrenal saliva test because I'm finding so many people's adrenal glands. I'm doing sitting and standing blood pressures and pulse rates for ruling out POTS. So, I always think of the MSIDS model with the testing, making sure that, we looked at mitochondrial dysfunction, have we looked at all these things? So, do you do a similar kind of lab profile when you're looking at these patients for the first time or they're staying ill?
I do, yeah. So I'll do saliva, I'll do blood, I'll do urine for organic acids, I'll do urine sometimes for metals, and for mycotoxins, of course. Depending on the patients, I'll sometimes do blood for Cunningham panels where I'm looking at neuroinflammation, which has the tubulin and CAM kinase antibodies and anti-dopamine 1 and 2 antibodies. So some of that is really helpful for neuroinflammation, especially if I'm thinking, especially if they're younger, and I'm thinking, may they benefit from some immune modulation like gamma globulin,
And
in
you're
addition.
talking the kids who may come in with PANS pandas. So just again, if you're listening, Steve's talking like the Cunningham panel that has these five auto brain antibodies that shows you whether you may need immune modulation, right? You're talking about normally these PANS pandas
Correct.
kids.
In addition to the active infections, while I'm looking at active infections, and
Right.
then yeah, and sure, and I'm looking at a few other markers, some soft markers like the VEGF, which sometimes can give us a sense of Lyme, the Bartonella. However, that being said, since I'm also doing shoemaker panels looking for mold, VEGF and mycotoxins disease is or SIRS or systemic inflammatory response syndrome is often very low. And so sometimes you'll see a normal VEGF and they have Bartonella and they have mycotoxins in it, just as speciously normal. So you got to take that into account. I do ammonia, plasma ammonia levels. I look at methylation pathways oftentimes, especially if they're very sensitive to treatments that they've tried over the years. And I'll of course do the Patterson panel, the Radiance Labs, looking at the cytokines and chemokines, very helpful testing for me. I'll look at eosinophilic cationic protein sometimes for Babesia. It's a soft marker of Babesia, of course, but we do see, and I can track it sometimes. I mean, look, if we had those markers that John Alcott is really looking for that we could truly track disease with, years ago when they were talking about CCL10, as a really important chemokine marker of Borrelia. Like if we had these tests that we could do, it would make our lives a lot easier.
So yeah, again, for those listening, Steve's discussing John Hopkins University was discussing CXCL9, CXCL10, CCL13, by the way, is neurolyme. You'll see it in neurolyme, and CCL19 they see in chronic Lyme. But unfortunately, there's no labs that run these. It's like they're great markers that you will see sometimes in the chronic Lyme, post-treatment Lyme disease population, but you can't get them from the local labs, right? So by the way, if I ever get John to respond to my emails, that maybe he would want to do part of the study I'm trying to do on Dapsone with this multi-center trial. I keep sending him emails like, John, I'm going for NIH grants. Do you think you might be interested? I think he's like weighing it in the background. Then I'll be able to get, by the way, those markers because then
Yeah.
we'll have John Hopkins. So I'm crossing my fingers. We'll see what happens.
Yeah, and still in the research world, one of the things that's gotten really big with precision medicine is metabolomics. So looking at all of the different metabolites we can find. I mean, of course, you have to create the panel in advance of what you do, but Bob Navio, when he was looking at cell danger response, he would have very broad metabolic panels that he was looking at via mass spectroscopy. And so some of that mass spectroscopy is not very convenient to do for diagnostic testing, but once we we can find, and using big data, using AI to find some of these panels and patterns among patients, I think we are getting closer and closer to having some of these markers. Because so much of this has to do with real-time data. We want to, yes, we make a diagnosis and we can follow people, but one of the, I think the perils of what we do is that we do have to use clinical response so many times in tracking how our patients are doing. And while that's very important, what it doesn't help with is that 4 years down the road, someone has some immune response where they get in a car accident and they have a huge sympathetic load and cortisol goes up and their immune system function goes down, and then all of a sudden their Lyme symptoms come back years later, or they get a root canal years later, and then all of a sudden these old Lyme symptoms that they had because we thought they were successfully treated because their labs were negative, it would be really nice to have some of these panels.
No, it's a great point. The one good thing I have seen about Dapsone, and this is going to take time, obviously, to prove, but ever since we discovered about a decade ago that Borrelia burgdorferi and Bartonella species are biofilm persister bacteria, what I have noticed is, my wife is going on 6 years in full remission. She's had a lot of stress in her life, including the last election, which, a lot of patients, as you said, they're in stressful situations. They get divorced, they're in a car accident, the symptoms will come out. What's interesting is that when you've knocked the load of these organisms down enough, and we can't really say cure 100%, but I have many patients in long-term remission from doing these persister biofilm protocols. You can speak to yourself if you've seen some of these, but I find for Bart, on the average, after doing the 9-week oral Dapsone protocol, finishing with a 6-day high-dose pulse for Bart, I need at least 4 pulses for Bartonella roughly every 2 months. Otherwise, the Bart is hanging around. And I've had people go in remission for a year where they have absolutely nothing. They look like, they might be cured. They get a cellulitis. The doc puts them on Augmentin, and all of a sudden the Bartonella stretch marks come out, and it's like, oh, the Bartonella was hiding in the body. And so Bartonella, in my opinion, is even way more difficult to get rid of for Lyme, which is why when we're designing this randomized multi-center placebo trial, I'm going to speak to a statistician tomorrow to figure out like how we can do this, like whether I can do this a year out, because ultimately I need multiple pulses. But I will say the hope for the Lyme community, and I've seen it, if I keep knocking down these loads enough, then when they're in a stressful situation, or they get a COVID vaccine, because I've seen a couple of people reactivate when their immune system got overstimulated for getting a booster, not often, but it's happened. The ones where I've knocked down the load and I've dealt with the MSIDS factors, we've cleared out the mold and their adrenals are in good shape and they're sleeping well, and we've cleaned up everything. A lot of times they do actually quite well long term. It's, of course, you're right. I mean, it's going to be a question of whether 99.9% is gone and we got a few hanging around in the background, but that's why you always need a good, healthy immune system. But I'm pretty hopeful based on what I'm seeing. But you're bringing up some great points that, for me, these newer biofilm persister protocols, I'm seeing a lot more success long term, where I'm not seeing those kind of relapses like I used to all the time, by the way.
Yeah, no, I appreciate that. Just to finish up, I think, now with COVID and some of the work that's been done about how spike protein persists, and then when you have spike protein that's hanging around in the body, and then there's concussion or there's Lyme, some of the stuff that Chad Prusmack has found, that these patients there are some long-term sequelae that can happen. So I think it is important. I do some clotting studies, like microclot testing. I'm starting to do more and more that looks at amyloid clots that can predict how much spike protein is affecting the body. There are ways to evaluate spike protein even these days, direct spike protein, not just antibodies. So I do think that that's also important. Of course, looking at chlamydia pneumonia, mycoplasma pneumonia, all of these other usual suspects, Brucella, Steve Phillips has talked about Brucella a lot. And I think it's really important because we're going to find it. Ebony Cornish has talked about toxoplasma a lot. And it sometimes, like, there is crossover with what we're looking at, and then the treatments are different enough that I think it's really important for us to know if there's a Brucella piece or a toxoplasma piece or some of these other intracellular infections that we're dealing with, not to mention viruses. So I think it's also very important to get viral panels and some of these other intracellular
Oh,
infections.
100% agreed. In fact, with the long COVID cases that we see from radiants, we see Epstein-Barr reactivation and herpes virus 6 reactivation not uncommon in these patients. And one thing I found in the literature a couple of years back is, and I haven't had enough experience using this, turns out that persantine dipyridamole seems to get where the Epstein-Barr is hiding in the body. I found this by accident in a PubMed search actually a couple of years ago, and that's something that needs to be looked at because when I did the search on it to find out what is the dosage, is it 50 TID, 75 TID? I couldn't get a clear indication. I don't think there's enough studies, but there are some studies showing that there may be some novel ways of knocking those viruses, apart just from getting our natural killer cells and T cells in order. But I agree with you. The Babesia will suppress your immune system's response to other parasites. And Toxo is very genetically similar to Babesia. So we've had patients with intestinal parasites that don't go away until the Babesia was kicked, right? So you're right. The bacteria, the viruses, the parasites, and ultimately even the fungus, right? Whether it's Candida overgrowth in the gut or mycotoxins, all four are definitely playing a role in these patients, and they all need to be evaluated.
And I think for the patients who are listening, that your doctors and you as clinicians, you don't need to test everything on everybody, but you do need to think or at least consider many of these different things that are going on, that it's not just, and then you've shown it. And I think the whole model of good medicine is showing that it's not just one organism is creating one constellation of symptoms. Like it's all this stuff coming together. It's your MSIDS model, and it's this aspect to chronic health, chronic illness, that we have to consider, that it's not one thing causing it, but it's sometimes the whole truly is greater than the sum of the parts.
Yes, no, agreed. I don't know if you know this, but the new book, I got a contract for Simon and Schuster to write my third science book, and I'm in the middle of working on it. And I got the idea of just checking out with the MSIDS model how it applies to these other diseases. So I started with Alzheimer's, and I found out that all 16 points on the MSIDS model applied to Alzheimer's. Then I looked at ADD, ADHD, all 16 points on the MSIDS model. Then I looked at autism, all six. It's like, oh my God. It's like all these chronic diseases. So it's going to be a fascinating new book. The title will change a million times, but it should be out in early 2026. And it's really about the paradigm shift that we need right now for chronic disease medicine. Long COVID, I published it this past year, all 16 points on the MSIDS model. I would like to go back to a second, though, with the microclots you're finding, because I don't know that a lot of doctors, by the way, are doing the kind of testing you're talking about. There's a lot of theories behind why people are sick with long COVID. They have the MSIDS factors. They have POTS dysautonomia. They've got mast cell activation, the endothelium, right? There's inflammation going on in the endothelium. There's microclots with spike proteins. There's a lot of theories going around, but we don't have, long-term trials. I'm trying some of these patients on the Maraviroc pravastatin by Bruce Patterson. Do you want to talk just for a second, Steve, about the assays you were talking about? Because I don't think a lot of docs are doing it, and how you're using it, and what you're finding to be helpful.
Right. So this used to be a home brew test where people would send in their blood and they would look at it under a microscope, watching the blood clot. So this has been done in alternative medicine, complementary medicine a lot. I mean, obviously it was done in regular medicine until probably about the 1950s. And now since then, it's somewhat frowned upon for us to use microscopes in our office, for evaluating blood, interestingly. But there is some interesting thing. Med Health Clinics is one lab that does it, and there's more labs that are looking at how biofilms and how blood is actually starting to clot. Back when David Berg was doing his Hemex work and looking at soluble fibrin monomer and some of that initial work, how
TAT, thrombin, antithrombin complexes, right? All that stuff we used to see years ago. Yeah.
and that stuff is still real. It's still a thing. And so one of the earliest theories about COVID and why COVID is so dangerous is that microclots turn into macroclots. And once there's a macroclot in the wrong place, then bad things happen. And so if we can see this system happening early, then we can predict how things how things may look if they go untreated. And the nice thing about these microclots is fibrinogen has a lot to do with them. And so using fibrinolytics early on in some of these diseases, such as nattokinase and lumbrokinase and serrapeptase and things like that, and sulodexide, which is available in Europe currently, and some of these other things, and maybe the dipyridamole that you're talking about may have some benefits for making the body not go into such a hypercoagulable state.
So, Steve, one interesting point, and I didn't know I was doing it, is, when we published the first COVID article using glutathione right back in April 2020. And I did it because I'd had Babesia cases where they'd come in short of breath. I give them a shot of glutathione, 2,000 milligrams, and within minutes they'd say their shortness of breath cleared. And I said, okay, glutathione, it blocks NF-kappa B, the switch inside the nucleus, along with N-acetylcysteine, alpha lipoic acid, but maybe also glut was pulling out stuff. So I started using it and we found it was working. That's why we published the first article. By the way, that article's been cited, I think, almost 300 times more than any Lyme article I've ever published. It's ridiculous. But I didn't know at the time, because you're talking about microclots, that N-acetylcysteine interferes with von Willebrand factor and it stops clots. And do you know we have not lost one patient who has died, not one in the last 4 years, as long as they've done the protocol that's on our website, cangetbetter.com, under the COVID tab, where I was giving all these patients NAC, alpha lipoic acid, glutathione, and I didn't realize at the time I was indirectly stopping microclots from forming by giving him NAC. And it turned out that the COVID virus, to replicate, as well as, by the way, influenza, dengue fever, HIV, many of these viruses, they need to lower glutathione to replicate. I didn't know that when I was publishing the article, but it turned out it's been extremely useful. So I think, maybe part of the reason I've had the good clinical success we've had, where no one's died early in the pandemic, might have actually been I was stopping the microclots and I didn't even know it at the time using NAC with glutathione.
All right. Yeah.
Yeah. Yeah. Kind of cool. So have you been using any of those anything you're seeing at this point, or your ear to the ground at this point that's working, apart from like PEA luteolin for mast cell for long COVID, and anything you're hearing from colleagues and stuff that seems to have some promise at this point?
No, I mean, I think that there is a lot of hope with the Sulodex side. And we can't get it here. I think it's mostly available in Italy. And so we don't have the data to back up, here at least what we'd like to do with it. I think right now the lumbrokinase is still, for me, the best thing there is. I do feel, it gives a measure of safety to these folks. Now the problem is that if people have bad Babesia and you give them a high dose of lumbrokinase, and then especially if you add nattokinase, I see a lot of patients flare, especially when I'm using dapsone or tafenoquine, and I feel like we're making progress, and then we want to kind of squeeze it, and then I add my fibrinolytics later on, especially the high dose fibrinolytics. Those patients seem to get sick for a while. So it is a thing too, that when you remove some of these fibrin sequestrations, that you a lot of times you're going to pull out and open up these organisms, back into general population. So it's so I think we need to be careful with it, and I definitely think that in the form, back to the microclotting, if we could find some things that are a little bit more specific, that aren't going to open up all of these biofilm related structures for these other organisms, then it's going to be really helpful.
Yeah, the way we support the HERCs is again, blocking NF-kappa B with NAC, alpha lipoic acid, glutathione, stimulating NRF2, a second anti-inflammatory pathway, curcumin, turmeric, broccoli seed extract, sulforaphane glucosinolate, resveratrol, green tea, blocking NLRP3 inflammasomes. By the way, all these are important in COVID too, right? Lyme and COVID, they all using a little bit of low dose melatonin with low dose naltrexone. And, you can also use things like omega-3s for the prostaglandins. There's a lot of things out there, but we're finding.
Yeah, sorry, just to interrupt for 1 second, because just what you were saying is that when COVID hit and the Lyme docs were like seeing COVID, we already had all that in our armamentarium. And so it was like, yeah, we just do this, and this. And these patients responded beautifully to this.
Yes.
Like, I'm not saying that we knew how to treat COVID. That's not, I'm not saying that, but the same mechanisms were at play there. And so, yeah.
Right. Yeah, no, we had an advantage because we'd seen Herx's and we knew how to block it. And by the way, you also don't hear this about COVID, but when the people were dying of ARDS, acute respiratory distress syndrome, which for those listening who are not doctors, this is when you go into the hospital and your lungs fill up and they white out and you basically can't exchange oxygen. You die basically from this complication. And dexamethasone and steroids were used, but it also suppresses the immune system if you have parasites and other infections. It turned out that dapsone, and nobody knows this study, they gave it in 40 patients in a trial. Now, one person died with ARDS with 100 milligrams of dapsone because it interferes with an enzyme called myeloperoxidase, which is an inflammatory enzyme, and it stopped the ARDS people from dying. And it's the same thing with Alzheimer's. There's studies on Alzheimer's using 100 milligrams of dapsone for 15 years in a Korean study with these leprosy patients. They found that the people that took dapsone for 15 years, the Alzheimer's rates were almost negligible. And the ones who didn't take it, their dementia rates were off the wall. And they didn't know, was that because we were indirectly treating Lyme or we're just blocking neuroinflammation using dapsone, which is part of what it does. But it's fascinating. The drug has been out there for like 50 plus years for leprosy. It's turning out to be used in all of these other pathways. And I think we're going to find as we repurpose these drugs as time goes on, it's going to be one of those drugs that I think is going to really turn out to be a blockbuster. And I hope I get this randomized trial done, at least started by the end of next year.
I sure hope so. And then just because of using dapsone, you've helped put methylene blue back on the map too. And methylene blue has become one of the most important agents that a lot of chronic illness doctors are using now. It's phenomenal for what it does. Everything from clearing brain fog to acting as a methylator to working even on parasites to working on Bartonella. I mean, it's phenomenal.
Right.
Yeah.
And in fact, in the Alzheimer's research, they use very low, end up using very low doses too, like 5 or 8 milligrams of methylene blue for mitochondrial function, right? I mean, they're using extremely low doses.
Right. No.
Yeah.
Yeah. Yeah. It's great.
Yeah. No, it's interesting how all of this stuff, intersects over the years because you're right. I was using methylene blue to lower methemoglobin levels initially. And then it turned out John Hopkins research was showing that 6 days in culture for Bartonella, if you did like rifampin, zithromax, and methylene blue, it was killing Bart persisters. What they didn't tell you was how much of the methylene blue was needed. And ultimately, after years of playing around with the dose, at least I found so far that we needed the top dose at 300 twice a day. We just have to go up very slowly and make sure people are not on psych meds or things that cause serotonin syndrome. But so far, we are having success. And I fortunately had not had to use things like IV gentamicin anymore, which years ago for Bart, I had nothing in like the really sick Bartonella patients. So, pulse therapies with persistent biofilm agents, looking at the MSIDS factors, it's really been a game changer in the last decade.
No, I agree. Yeah, I
Yeah.
absolutely
Yeah.
agree.
So, Steve, we're getting kind of to the end of the hour. So, any other like clinical pearls or anything else? And by the way, where can people reach you if people have questions they want to reach you? What's the best email to get in touch with you? And any other kind of clinical pearls you think you want to share just to kind of wrap this up for us?
Right. So I work now I do consulting with Gordon Medical Associates in San Rafael, California. And I do have a book coming out in the near future, probably in April, called The Order of Treatment, because I do think, and we didn't really get into order of treating things, but so there is that to be had. But yeah, Gordon Medical Associates, probably.com at this point. It's probably the
Eric,
best way to get a hold of it. At this
Eric Gordon can be so pleased to be able to hear that you have another website by now. Thank you so much. Yes.
Right. Yeah, I mean, clinical pearls, I mean, really is that, I mean, it's more about that there's so much amazing work now in mitochondrial research, and that when the MECFS folks and the long COVID folks and the Lyme folks are coming together, and and some of these neurodegenerative illness folks are coming together, the research is really starting to intersect, and the treatment strategies are really starting to intersect. That there's and taken to when you take that with regenerative medicine and some of the findings that they're having with exosomes and with stem cells, and different kind of cellular therapies. It's and peptides, the world of peptides, and then possibly some of the the lack of regulation that may happen to allow certain peptides to be used, over the next several years. Um, I think there's so much hope for people that even if people feel that they've done everything before, they haven't done everything because there's always new things that practitioners working with researchers are finding, and that like there really are answers available for people even when it seems like there's no hope. So my major point is that you haven't done everything, that there is to do for diagnosis and treatment of your conditions.
Right. And I agree with you. We really can give hope, which is at this point really grounded in good science and in good clinical research. We are having much better success, right, in this past decade since the researchers in the major universities discovered what they discovered with the biofilms and the persisters. And of course, all the research, as you say, that's been done on mitochondrial function, on POTS dysautonomia. I mean, all of this has come together basically for the Lyme community and help people. So, Steve, I want to thank you for taking the time out of your busy day. I know you got to get back to patients. So again, we've been speaking to Dr. Stephen Harris. Steve, good friend of mine, has been doing Lyme for 25 years. One of the great practitioners in the field these days. He's working for Gordon Medical. If you want to get in touch with Steve, Steve, again, thank you for taking the time. And my name is Dr. Richard Horowitz. I'm co-host of the Doctor Talk Healing Lyme Summit 2.0. We've been discussing how to use lab testing today for chronic Lyme and some of the integrative therapies that are out there. I hope you'll join us again soon. Thank you for taking the time to watch. Bye-bye.